I know you are all joining. Welcome. Good morning, good afternoon, good evening, wherever you are joining from. Please put your small introduction in the chat so we know each other. Who are we? My name is Jabeen Fayaz. I am a merge doctor as well as a simulation educator, and it's my utmost pleasure to have coming with you and joining with you all in another interesting and fascinating webinar. Today's panelists are Dr. Saeed Uzair, Dr. Akhtar Hamid, and Dr. Umar Hayat. Some of the housekeeping stuff. Please continue to participate. We will be starting in next few minutes. This session will be recorded, audio and video recording, and it will be later available in the YouTube. So please keep this in mind. And there is a WhatsApp as well as YouTube channel. Please join and we'll share the links in the chat. With this further delay, with this, I would like to introduce one of my very good friend, colleague, which I'm working for last couple of years, Dr. Faisal Ismail. Dr. Faisal Ismail is a regional director at the Center for Innovation in Medical Education at Aga Khan University Hospital, Pakistan, and an associate professor and gastroenterologist in the Department of Medicine. He is a certified healthcare simulation educator with a master's in healthcare simulation from the University of Alabama. He has a strong focus on interprofessional education and healthcare simulation. I call him my partner in crime. He allows me or enable me to do a lot of work which I'm passionate about. And he is also the vice chair of education in the Department of Medicine. He leads undergraduate, postgraduate, and faculty development program, served in various leadership roles, including director of GI residency and F.R.C.P fellowship programs. He has also served as a director of endoscopy unit and contributed to quality and patient safety committees. He's an award-winning educator and researcher and a senior fellow of the Higher Education Academy, UK, an inaugural member of the Teachers Academy at AKU, and he also served on the editorial boards of many renowned peer-reviewed journals in the field of gastroenterology as well as healthcare education. So with this brief intro, there's a lot that I can keep on talking about Faisal, but I will hand it over to him to talk about today what is the Pakistani healthcare simulation landscape is, where are the opportunities he sees from his lens, and what are some of the threats. So Faisal, welcome, and I will hand over to you now.
Assalamu alaikum and good morning and good afternoon to everybody. And before I start, I just want to say thank you to the whole APPNA MERIT team, particularly to Dr. Jabeen. It was Jabeen who first told me about this and informed me about this. And before we all got started, all of the panelists were also talking about how, mashallah, Jabeen is such a she's a person who makes things happen and is a facilitator. So thank you very much for giving me this opportunity. As Jabeen said, what I'll be trying to talk about in the next 40 minutes over here is just to tell you a bit about healthcare simulation in Pakistan, particularly because I work here, I live here, and I practice here. So I think perhaps my insight over here will help you understand the context in Pakistan, and perhaps together then we can understand the challenges, the facilitators, and work towards how simulation may be given a boost here in Pakistan. I'll go ahead and just share my screen.
It looks good, Faisal. You can.
All right, thank you very much. So I'll start off. I do not have any relevant disclosures to make. My talk over the next few minutes is going to be talking first about the imperative to use simulation in healthcare education. I'm aware that not everybody in the audience today are simulationists, and we perhaps may have people who are not totally convinced about the utility of simulation in a country like Pakistan. So I'll be talking a bit about that. I'll be laying out a bit the lay of the land in Pakistan, talking about the threats and challenges, and then also opportunities and facilitators for simulation in Pakistan. Uh, and I think this is one of those fabulous quotes which all of us who are in clinical medicine will totally agree with, is that clinical experience alone, unfortunately, does not guarantee the acquisition of clinical competence. And we've realized this, that just by spending X number of years in a residency program, the product that may come out at the end of that residency program can vary so much. And when we've therefore realized that time alone is not the best indicator of clinical competence. And this was one of the major push that simulation got, which was in the year 99 when the IOM report came out, to Err is Human, which described an incidence of 44 to 98,000 deaths annually from iatrogenic errors. So these were errors that we as healthcare staff were making on our patients. Further reports over the next few years showed either 575,000 deaths and somewhere then the range between 210 and 400,000 deaths annually just by medical error. But you will agree with me that it's not a question of 44,000 deaths or 400,000 deaths. Even one death due to medical error is a tragedy, and that's something that we should try to ensure that never happens. And that started the ball rolling as to for people to determine as to what were the causes of these errors and what can we do to prevent healthcare professionals from harming our own patients. And one of the main reasons why this happens is unfortunately, all of us realize now that modern healthcare is extremely complex and very fragmented. And if any of us have had our loved ones or unfortunately have been admitted ourselves, we realize that patients tend to see many different health professionals over the course of an illness, from the different consults that are given in a medical team, to the physiotherapist, to the pharmacist, to the nurse, to the allied health person. There is a group of people who look at patients when they're admitted. And the IOM report and other reports show that miscommunication and procedural errors within teams were the cause of 80% of all sentinel events. And therefore, there was clearly a relationship between teamwork behavior and clinical patient outcomes. And the better teams worked, the better patient outcomes was, and vice versa. So teamwork and team building was something that was coming out as essential to modern healthcare to improve patient safety and quality. So team training was something that was used in other professions for decades, and we healthcare, modern healthcare requires interaction of individuals from diverse backgrounds working together, and in a very high stress, high stakes environment with time pressures. So if any profession needs team training, it's us, it's the healthcare profession. And this is a quote that I liked very much, which came in academic emergency medicine, which said that we can say that the physician or the nurse that looks after us may be an expert. But can we honestly say that the team of professionals that looks after us are experts? And answer, unfortunately, is we possibly cannot say that most of the time. And therefore, team training is something that came up as essential for simulation. And simulation is important because on the job training, when it becomes expensive or risky, is where it steps in. And it's been used in the aerospace, in military, and nuclear power plants for many, many years. Medicine itself is an extremely high risk industry. And that's where simulation should have been used and should have been adapted a long time ago, but we didn't, unfortunately. And it's only now, with the past 10 years, that simulation is really gaining traction and people are realizing the importance of it. And the clear benefits of simulation over traditional medical education, the way you and I have been trained in the past 20, 30 years, because it gives you sufficient opportunities for practice. It gives you exposure to infrequent scenarios that you may not get to see in real life and therefore may not be able to manage when faced with in real clinical practice. Then we realize that people and candidates and participants learn at different stages, and therefore simulation allows you to tailor the scenario to each individual student's needs so that they can practice as many times as they want and become as good as they want to be. It affords you standardization. Affords you patient variability. I still remember when we were preparing for our exit exams in the FCPS and MRCP, we used to wait for any patient to come in. And once, for example, if there was a good murmur somewhere on any patient, a MS or an AR murmur, then the news would go around that in C2 ward in 220B, there is a patient who's admitted with a great murmur. Listen to him before he's discharged or undergoes surgery. You don't have to do that anymore now. With simulators there is an opportunity to provide all the variations you want on demand. It promotes team-based learning. Feedback and debriefing is essential to the component of simulation. Simulation is not considered complete without feedback and debriefing, and therefore that's a very important thing to have. And it's still under instructor control, so the instructor can guide the participant as to how they want to proceed. So, why use simulation? It's a safe environment. It's mistake forgiving. You make a mistake, no problem. No one's hurt. You can just get some feedback and restart. It's trainee focused versus patient focused. So, and I give the example of the fact that I'm a gastroenterologist and I teach endoscopies. But when a trainee of mine is doing an endoscopy, my focus is not on the trainee. My focus is on my patient. So if the patient starts to become hypoxic or tachycardic or becomes unstable, I will take the scope from the candidate immediately. Now that causes a lot of psychological harm to the participant. His training is hampered. He hasn't got the training that he wants. So simulation is different from real life because it's not patient focused. It's trainee focused. The participant is focused on his training. You as the facilitator are all focused on the training. So the output that comes out of that training is so much more superior than the training that happens on the bedside. It's controlled and proactive, so candidates and facilitators can choose the time they want to go and have that clinical exposure. I said a little while ago, it's reproducible, it's standardized. And I think if people learn that this is the way physicians are trained in Pakistan, that they have to undergo simulation training before they come to real patient, think of the increased public trust in the profession. That is that unfortunately a lot of people in our part of the world are not trusting of the healthcare professionals. And I think that is going to add a lot of strength to the profession if they understand the training we undergo. And it offers you opportunities for deliberate and repetitive practice. But you don't need to take my word for it. I am a simulationist. What does the science say? And the science is overwhelmingly supportive of the use of simulation. These are just three things that I've put in as far back as 2020 and 21, where it's cardiac outcomes you're talking about, endoscopic skills you're talking about. Um we've gone beyond the conversation of saying, should we or should we not use simulation? The conversation now is where can we best use simulation rather than thinking if it works or not, because clearly there is overwhelming evidence to say it works. So, to just summarize the past 10 minutes, we know that simulation is important because it allows people to rehearse elements of clinical care in patient safe environments. It's a positive, learning friendly environment. And the ability to pause, give feedback, restart, and replay the clinical encounter is so invaluable to develop skills. And finally, gaining the expertise requires constant focused practice, not time. It's not time that's determinant, it's constant focused practice. And simulation allows you to do that. So, these four bullet points are the main reasons why we promote simulation as something that is the need for healthcare education globally. These are just a few simulation technologies that I used, and I use this over here because it's a myth that unfortunately simulation equals high fidelity mannequins and expensive equipment. And this is over here just to show that simulation is a technique. It's not the name of a machine. Simulation is a technique which offers the candidate chances to practice and become a master at what they're doing. And you can do that by using computer-based simulation and virtual environments, AR, VR, which is the rage these days, task trainers, low fidelity simulation, the standardized patients that we use in our examinations and as well in learning skills. So I would want, this is something I say often, and I would want my audience today to also remember, please, that simulation is a technique. It does not equal high fidelity simulation, which is unfortunately one of the challenges that we face here in Pakistan. Now, the Pakistani context is slightly different, and I'm sure all of you know this because of your repeated trips to Pakistan and while you were here in medical college. Our population is now more than 200 million, and we have a healthcare model which is primarily based out of pocket payments. And when you're talking about a country like Pakistan, where there is so much diversity in terms of paying power, then you can clearly understand that there are significant disparities in care. And the type of care that is given to a patient in a village in Bahawalpur is not the same as the care given to in a tertiary care hospital in either Lahore or Karachi. Unfortunately, medical education institutions in Pakistan still use didactic lectures and the apprenticeship model and small group clinical sessions for clinical skills education. And that is why it's important to understand that the MBBS or the bachelor's in nursing or the allied health product that is comes into the market after their teaching and learning is very non-homogeneous across the country. It's not the same standard, and therefore it is extremely important that we have some teaching or training at postgraduate level, but also at undergraduate level to produce a product that is of a quality that can at least somewhat be standardized across the country. Then, when you come to postgraduate training, you will all realize that the postgraduate training in Pakistan is also not standardized. So there may be residency programs where people may go through a whole 3, 4 years without even seeing a particular type of patient or doing a particular type of procedure. And there may be others where patients are like that are coming in daily. So the quality of the product that is produced even in postgraduate training is not equal. And finally, once people graduate in Pakistan, there is no pressure for continuing professional development, unlike it is where you work in the West, where you have to stay updated and make sure that you achieve your certain number of credits for your professional development. It's not that way in Pakistan. There's going to be no bar placed on your practice if that doesn't happen. And unfortunately, these are reasons why I feel that simulation is much more important in a place like Pakistan because of the non-standardization of teaching and training in our part of the world. Now, there are thankfully places that are coming up in Pakistan. The biggest center uh, right now is the center where I work in, which is the Center for Innovation in Medical Education. And there are three other simulation centers. There are a total out of the four centers, there are three in Karachi. There's one in Liaquat Hospital, there's one in Dow University, and there's a large center called the Clinical Skill Lab in the PGMI in Peshawar. Unfortunately, the rest of them are mainly skills labs. And when I say skills labs, I mean a room, a large room, or perhaps two rooms where simulators have been stuffed in to be used on a need basis, as opposed to a center which is a purpose-built center. So this is the current state of simulation centers in Pakistan. So to understand really the factors, what are the ones that are key in the uptake that can affect the uptake of simulation? We conducted a scoping review, which we published just last year, where we looked at not only Pakistan but the developing world in general, because Pakistan's problems, like most developing worlds, are generally the same. So we looked at a total of 48 studies there, and I'll be talking a bit about this because this perfectly illustrates the problems that we have in Pakistan. So when we talk about the challenges in the Pakistani context in the uptake of simulation as a teaching tool in under and postgraduate healthcare education, then what we found was that you could broadly classify the challenges into three areas: academic challenges, resource-based challenges, and professional factors. And when we spoke of academic factors, then we could divide them into themes of curricular, factors related to the curriculum, factors related to being from the educator's aspect and from the learner's aspect. And when we spoke of the curriculum, we realized that one of the main challenges was that our curriculum that is still being taught in our medical colleges is still not context specific, and therefore people talk about the fact how we should even incorporate simulation when we are not even studying the main diseases that we should be studying in our part of the world. We're studying about, and I still remember one person telling me that we're studying about multiple sclerosis and inflammatory bowel disease when we should be talking about TB and malnutrition, which is to some extent true. Then a lot of the current curriculum is very content heavy, and that is one of the main factors that is dissuades people from taking up new methods of teaching and training, because they say that the curriculum is already heavy. There is no place for us to incorporate simulation. As on part of the educator, people felt that one of the main key areas in Pakistan, which is not allowing the uptake of simulation, is there aren't many people who are trained to do simulation. And then when you have a lack of familiarity with this, with simulation, what it is and how to deliver it, then there is always a resistance to change from conventional pedagogy. A lot of the senior professors and people who teach and train are very happy doing things the way they were taught and the way they are used to doing. So teaching with a PowerPoint presentation and throwing participants into the deep end by telling them to go to the ward and just practice on patients is something that happened to them. So they are comfortable in doing it. So they just want to continue it. And interestingly, another factor that was pointed out by a lot of people is performance anxiety. The fact that they don't know how to use simulations or deliver simulation training, so it makes them anxious about the way they will perform in front of their learners. When you talk of the learners or the students, one of the things that they said were challenges in Pakistan were the low quantity of the equipment and the quality of the equipment. And this stems primarily from the large number of students. To all of you who've done their MBBS from Pakistan, you know that we come from classes which are 250, 300, sometimes even more than that. So a lot of the learners were of the opinion that how can we even think of doing simulation when such a big class comes in, and then the quality of the equipment is not even there. Learners themselves were resistant to the new ways of learning, and of course performance anxiety, that when they'll be practicing on the simulator, they'll perhaps not do as well as they can, and the peers will pick it up, and so there's peer anxiety from there. There were factors associated with resources, particularly the cost of purchasing and maintaining simulators, poor infrastructure to manage them, and lack of trained personnel, particularly the technical parts who can look after the simulators technically. And finally, there were professional factors. A lot of the faculty in medical colleges and in nursing colleges talks about competing priorities. For example, we know that as teaching and training takes a lot out of us. And a person who's in private practice or practices, clearly there is a financial disparity there. I mean, you can clearly make a lot of money just by seeing more patients in clinic, which is, so there's that competing priority for faculty for training versus financial remuneration, which is one of the factors that uh, is a deterrent in the uptake of simulation. Then there's leadership, interest, and support. I still remember up till 3 or 4 years ago, my leadership used to tell me that do we even need simulation in a country like Pakistan when there's so many patients already? You've got your training pool available everywhere, and there are still these mindsets that you have to argue with and convince leadership about how it's not right to practice on patients, and how for patient safety it's important that patients, participants and students and doctors are trained before they touch patients. But for us to do that, protected time needs to be given to faculty, and that was one of the main challenges that faculty described, that there is no protected time given to us to develop ourselves and then deliver that simulation. So these were, in a nutshell, a lot of the challenges that we picked up to the uptake of simulation, but it's not all doom and gloom. At the same time, we identified opportunities as well, which could help us develop and push the agenda for simulation in a country like ours. And so these same factors, same themes. And a lot of the people thought that perhaps if we do make a decision to adopt simulation in our teaching and training, it could give us an opportunity to revamp the curriculum that has not been updated for many medical universities across Pakistan. And we could use better curriculum design and give opportunities for better training. A lot of the educators liked the fact that simulation affords you clear learning outcomes that you can do and the opportunity to give real time feedback. So there were people wanting to change the curriculum, uh, and they thought simulation would give them an opportunity to do that. The good thing was for both educators as well as learners, we saw that there was eagerness and motivation to use simulation as a tool because both groups realized the acknowledgement that simulation is a very valuable addition to training. And they realize the importance of patient safety and the ability to practice and become better. And a lot of learners like the fact that they, in the same patient, can just adjust the simulator or the scenario a bit and see it. So, for example, in one patient, you may be listening to a mitral stenosis murmur, but at the same within seconds, you can just change that murmur to a lung sound and listen to bronchial breath sounds if you want to. So the fact that you could simulate different environments within the same room made a lot of learners very enthusiastic about adopting simulation as a teaching tool. For resource-based factors, it is essential that a country like Pakistan has the availability of local simulators and low-cost simulators. And I know Dr. Jabin and others have been working on the development of this. Dr. Adil Khatri will be speaking in a few weeks as well, and he is working on that at Indus as well. So it's very important that we as a country cannot continue to spend hard currency in USD on simulators, and the way forward for us is low cost simulators, perhaps from other developing countries, and availability and look for local development of simulators. We have to invest in infrastructure. It's not enough just to have a one room with 3 or 4 task trainers thrown in them. We have to develop the infrastructure of a simulation center if all of us want to implement simulation in our curriculum. These can be a source of income generation for the country as well when you start making simulators, and gives you the opportunity to connect globally to a large audience. For professional factors, a lot of the faculty felt that it was an opportunity for them to provide mentorship directly to people when they're teaching tasks, and that was something that was very good. A lot of them loved the novelty of simulation and the personal satisfaction that you got when working one on one with a candidate or perhaps with a group, and you could clearly see their skills improving and the personal satisfaction it gave them as trainers. It needs leadership interest and support. So I would think that one of the key things that we all need to do if we want to implement simulation in our program is to first get the leadership on your side. Like most things, if you come from the top, it makes things easy. And I think there's got to be foresight for competing priorities for leadership and clinicians. Therefore, you've got to make sure that you remunerate your faculty adequately in some ways, in any way that the government and that the university feels appropriate, but that you've got to stop this competing priority for faculty where they need to unfortunately choose between teaching and training or financial remuneration by seeing patients. You've got to make it more balanced so that senior people from which juniors can really learn from can have the opportunity to give the time and effort to teaching and training. And it was because of all these factors that we realized that we needed some sort of push towards simulation in Pakistan. So this is a small roadmap, if you will, that if there's anybody in the audience right now or somebody perhaps who would want to think of using simulation in their under or postgraduate programs anywhere, but particularly in Pakistan, then what you've got to look at is a technical infrastructure. The second is resources. And the third is academic integration. I'll just spend one slide on each of these. That when we talk about technical infrastructure and technology management, then you've got to have a purpose-built facility to deliver simulation. It's got to have multimedia equipment, it's got to have hardware and software, and you've got to know how to manage it. It's one of the worst things that can happen is faculty comes in and they find out that I need to give a lecture here and I need to show something, and where's the multimedia? And that would mean, do I need to now go and get my own multimedia? You've got to make things as one window solutions for faculty to adopt simulation. The second is resources. And remember, if you make the center, but it doesn't have any resources, people are going to come once, they are going to get extremely irritated and disgusted with the fact that there is no equipment for them to use, and they're going to say, what are we going to do here? They're going to go back with an impression that simulation is useless, it doesn't work, and they're not going to come back. So make sure that when they come, you have the equipment to support them. You have the disposables that are ready. You have the gloves, you have the syringes, you have the gel that's required if they want to come and practice an ACLS scenario. You've got to have your faculty that's trained, that's available, and know how to run the scenario. And remember, you have to have a biomedical technician. Technicians are essential to the use of a simulation center. The worst thing that can happen is for a faculty to bring 20 students in, and then the machine, for some reason, has a technical error and no one knows what to do. And the simulation person says that, oh, we'll have to call the vendor now. And that faculty is irritated, disgusted, and is never going to come back again because he thinks it's a waste of his time to go to the simulation center. So you have to have the resources of a biomedical technician before you start calling people in. Trained human capital is part of your resources. Please remember that if you conduct your simulation improperly, that's not going to accomplish objectives. There would be poor learning and disengaged participants. So the way you deliver a good simulation session is by making sure that you have invested to train your simulationists. It's not all doctors unfortunately seem to think that just because they're doctors they can do everything correctly. Well, we know with time and experience that that's not true. You need to be trained to become a simulationist. You need to be trained to become a medical educator. You've got to know how to do it. And I think it's very important for people in leadership positions in universities to realize them, build a core group of champions who believe in the power of simulation, and train them to become simulationists so that they can conduct your sessions. Encourage continuing professional development and memberships of your staff so that they can afford to develop into good simulationists so that they can be then the reason for your center's success. And finally, you need to integrate the work that you do, the simulation, into the curriculum. Even at the Aga Khan Hospital, where we have the largest simulation center in the region, for many, many years, uh, our simulation was not integrated with the curriculum, which then made simulation opportunistic. So somebody like me who loves simulation would bring his students into the simulation center and we would practice and do simulation. But another colleague of mine who was not convinced of the power of simulation would just take all the students into the ward. So learning was haphazard, learning was not standardized, and we were not giving the best standardized exposure to a lot of our residents. So it was extremely important that through a process of planning, implementation, evaluation, and a revision again and again, the program director and the simulation expert sit together and determine where in this curriculum can simulation be integrated and then make it mandatory for you to do those skills using simulation. That is the way you will improve the quality of the product that is produced. Now you can realize that there's so much of work that goes into this. It's a massive task doing this anywhere in the world. I've met colleagues in the West who say it's been a struggle doing this, even in North America, to integrate simulation into curriculum. So you can understand in a country like Pakistan, where we have fixed ideas and minds and our intent to change is not very strong. We need a voice, we need a group of people working together to push the agenda for simulation. And it was for that just a few months ago, it's not even been a year, we conducted our first international conference on simulation called SIMPACT at the Aga Khan, and we launched the Network for Simulation in Pakistan. This is the first network where we've launched, where this is an attempt by people to come together who believe in the power of simulation as a wonderful tool to improve patient safety and quality and will want to work together for this in Pakistan. There are four broad areas we will work in to promote academic excellence, to promote continuing professional development and clinical services in Pakistan, to promote research and innovation using simulation, and to develop leaders and advocate for the appropriate and correct use of simulation in medical and nursing curricula in Pakistan. These are four very important and you may say very ambitious goals, but we think this is an important task to do. We think this is essential for us to do and something that we will work towards. These are just a few of our members. Like I said, we are a very young network, just been a few months. Apart from myself, what we've tried to do is make sure that we have representation from all parts of Pakistan in both the public and the private sector and from different professions as well. Interprofessional simulation and education is extremely important. Like I said at the start of my talk, we work in teams, we've got to learn in teams. So, these are other people that who work with us in the network. There's Professor Abrar Ashraf Ali from Lahore. There's Dr. Syed Farjad from Dow. There's Dr. Adil Khatri from the Indus Hospital Network. There's Dr. Jabin Fayaz, who's helping us from Sim Kids. There's Professor Ashfaq Ahmed. He's the Dean of Allied Health Sciences. Like I said, we are working with all professional groups. He's from the University of Lahore and a keen user of simulation. There's General Mukarram, who is at the CMH Rawalpindi. There's Dr. Mohammad Mumtaz, who is the director of the Clinical Skills Lab in Peshawar. There's Dr. Amna Anzar, who's in charge of the Professional Development Center at the Jinnah Sindh Medical University in Karachi. There's Brigadier Retired Rizwan Hashim from Fazaya Medical College in Islamabad. There's Miss Saima Khurram, who is a nurse who works at the Skills Lab at CPSP. She has been long history of working in simulation, delivering ETLS, AHA courses, and others. And she's the nurse representative. And there's Professor Dr. Waris Faruqa, who was very recently in the service hospital in Lahore and has recently shifted now to Bahawalpur as the principal of the medical college there. So we have a group. We're looking, of course, we very slowly and gradually we'll be building up this group, and this we hope is the group that's going to lead the effort to promote and facilitate simulation, raise the voice, and raise the awareness about simulation in Pakistan. This is our network of simulation logo, which just says that all over Pakistan we'll try to work, inshallah, to improve the quality of healthcare education. In the last few slides, I'll just end by a quote. Aristotle said it correct many years ago when he said that excellence is an art which is won by training and habituation. We are what we repeatedly do. And when we repeatedly do something, then excellence becomes an act. Not an act, but it's just a habit because we become so good at it. So I think that's what simulation affords us the opportunity to do, to teach and train and practice again and again and again until we're not making mistakes and we are the best at what we do. These are just a few pictures. I wanted to introduce my center to you in the last few slides. We the Akhan University, as you know, is across four different continents. We have a simulation center at the Akhan University campus in Nairobi as well. So these are a few pictures. The top left one is a session going on in Nairobi. The bottom ones are it's the IC, which is a cataract and eye simulator, and this was a tournament that we held with Aachen University and Harvard University, which was an ophthalmology tournament. On the right, you see us doing a first responder course for primary care teachers in Pakistan, and this is the way we teach them hands-only BLS and using simulation to teach and train the community. On the left side is a social media grab of in situ simulation. This is simulation where simulation is actually conducted in the hospital space to improve quality and pick up problems in real time. These are nurses practicing their skills in the NICU. And on the bottom right is our community apartment where we use simulation to teach healthcare staff of how to deal with people who are at home and the elderly who need care at home. This was an event that we did just pre-COVID. It's about time that we did it again. This was Sim Wars. For a lot of you, you may be seeing a rickshaw after many, many years. We got it into the simulation center to practice what to do with a road traffic accident. And on the right side, you're seeing a lady who's gone into labor in a shopping center and how she's being shifted into a hospital. This was a code orange that we did a year and a half ago. This was for the teaching of emergency medical staff. So these were people, if you can see, it's two or three people in a green uniform. This is the Sindh Emergency Medical Services. So we were teaching and training them on how to deal with mass casualties and if there is trauma on a large scale. So this was a simulation that we conducted for them. We have a lot of educational offerings. We do sim consults, which is a free service that we offer to anybody around the world who would want to, who want to, for example, do simulation but don't know how to start. Just log in at a particular time, and there'll be somebody from the simulation center in Pakistan who will be able to guide you. We do the clinical simulator educators program. This is where we teach healthcare staff on how to become simulation educators. We do first responder course for teachers, and we do a technologist program as well. So what we're trying to do is really increase our offerings in the field of simulation for different people who may need them. We use gamification in simulation a lot. This is something that's been coming up. We try to use Sims to improve quality, to improve training, and we realize that for this current breed of students, they are very different from us. They learn through technology. They learn, and if things are not interesting for them, they'll just disengage. So we use a lot of gamification and we push gamification in simulation. In fact, Dr. Jameen was talking about the IMSH, which is the largest simulation conference in the world. For the first time, we conducted a workshop at IMSH from Pakistan on simulation, which was, we felt really happy about that. People from Pakistan could conduct a workshop in the largest simulation conference in the world in North America to tell people about the use of gamification in simulation. We do some technological innovations as well. Um and this, for example, is an intubation box trainer on the left side. It costs about 900, the actual one costs about 900 US dollars. The one that we made cost 20,000 rupees. There's another laparotomy trainer on the right side. These are all in-house innovations, and there are many others that we've developed and Indus Hospital has developed and others. And like I said in my talk, that we've got to think of new innovation and local innovation in Pakistan if we want to make simulation accessible to all. So just to conclude, ladies and gentlemen, simulation offers a wide array of learning and assessment opportunities for training, and I would encourage all of you who do use simulation to please continue to use more and more of it. And for those who do not, I hope I was able to convince you to use it. We know that we should use it because it promotes patient safety and training competence. And we've got to start looking at simulation not through the lens of profitability, but through the lens of patient safety and of training and teaching. If we look at simulation from the lens of profitability, that I'm going to buy a $50,000 simulator, when is it going to pay me back? It's not going to pay you back in terms of finances, but it's going to pay you back in terms of the quality of the product of the healthcare professional that you'll put out and by reducing iatrogenic injuries and others, hopefully. Please remember, simulation is a technique. It's not a synonym for expensive machines, so don't equate the two. And remember, simulation does not replace human patients. It makes trainees safer and more competent to treat them. And that is the crux of simulation and why we feel it's so important to use in healthcare education. I hope you find my talk useful. If you want to reach out, I'd be happy to engage with you later on. This is our center in the Aga Khan. It's the Center for Innovation in Medical Education. Jabeen's been here many times, and every time she comes in, I do not miss the opportunity to call her in for a talk, and she's always obliges. It's extremely kind of her. But I'd like to invite all my colleagues and everybody else who's on the show that whenever you come to Pakistan and you're in Karachi, I would love to be your host and show you around the center and hopefully think of ways where we can work together. Thank you very much for your attention and be happy to take any questions that you may have for me.
Thank you so much, Faisal, for an amazing, comprehensive talk. You make me realize one more time why I'm doing all this, what I'm doing, and how much I'm blessed to have colleagues and friends like you, which I'm have an opportunity and pleasure and blessing to work with. So with this, I will open it up to our panelists if they have any comments, and then there are a couple of questions. I will take that later on.
Well, thank you, Faisal. That was a very extensive or a nice landscape of simulation you have done. I remember, I'm a Dow graduate, so I remember, I mean, there is a way to reach to a peak of your training. So if you start from here, you have to go from this side. So there's a two ways you get there. Either you go from by the curve up, or you can go from the curve down. So if you use the simulation, so you're using the curve up because you're not going on the patient's experience. So when we were training, we did everything on the patients to get to this point. Now, I think simulation will bring everything on this point with using the simulation without experiencing, or what I would say, without minimize morbidity or our training skills on the patient, poor patient. So that is something I've been witnessing, and it has been taken a next level. And I'm very pleasantly surprised that, okay, things are really working well in Pakistan at that. When Jabeen wanted to do this simulation at that time, this was not very openly used. So we did discuss that, okay, because I was in the simulation of C.H.S.E before, and I was not seeing much hope. When she came, she said, okay, we'll do, and it will. And now things are really changed.
Yeah.
So my question to you, Faisal, is I know the simulation you've been doing quite well in terms of having a faculty setup, equipment needs, resources, and the trained people. Are you integrating AI into your simulation, which can help, I mean, to go above and beyond your conventional method of doing simulation?
Yes.
Or how can an AI can help your simulation make it more better and more fruitful and either as a group setting or as an individual setting?
Thank you. Thank you so much for that, Dr. Akhtar. And yes, I think AI, like in all facets of our life, is making its presence felt everywhere. And the world of healthcare simulation is also using it from something very simple as, for example, scenario development to helping with debriefing and how to conduct a simulation, just from basic things like that to AI actually as part of virtual worlds, and the use of headsets and the use of AI and technologies such as augmented reality, to even the highest fidelity simulators, which actually help you give feedback. I think AI is impacting every area across the spectrum of simulation. So it's helping us develop better simulators. It's helping us develop better scenarios, and we will also be looking to incorporate that as and where we can. We've already starting to use it in our debriefing strategies. We're starting to use it in our scenario development. And I think as time goes on and we develop the software or the virtual worlds that are used for virtual reality, those will also be using a lot of AI.
So another question is maybe for both of you, perhaps Jabeen as well as Faisal, you, in your wisdom, when do you think we should introduce this simulation in our students? Year 3, year 4, because nowadays or before it was using it in the residency program or even in when you become a full doctor. So my understanding is it should be in the now in medical curriculum.
Absolutely. And perhaps I can let Jabeen go first and then I'll follow after her.
Yeah, I think in North America, it is part and parcel of from the undergraduate education, and not only in physician, but also from nursing, for PAs, for RT, respiratory therapists, like all specialty of the medicine are using it in the undergraduate curriculums. Some of the institute, and I'm pretty sure Aga Khan has introduced in the undergraduate curriculum. I know University of Lahore has incorporated into undergraduate curriculum. So like as much sooner as possible, you can integrate into the students in North America. Even the high school children are taught basic life support, etc., by using simulation actually. And I would say a lot of time in the Pakistani paradigm, they are doing simulation without knowing that they are doing simulation. They are thinking that they are just using dummies, mannequins, etc. But in fact, they are using simulation, role plays, everybody do in their teaching. And that is a form of simulation. I will leave it here. And Faisal, you want to add on something?
Yeah. Yeah,
जी
it was
बिल्कुल
more in context of Pakistan education. Sorry. Yeah.
Yeah.
जी so I can tell you about the Aga Khan University. We generally they start using it in year two. For example, I'll give you year two is not even a clinical year, but when they're learning about pathology and carcinoma, so they will for example practice and they're learning about history taking. So they'll use a standardized patient to practice their history taking skill of perhaps a lady with breast cancer. So they'll practice the history taking on that. Then they will use a breast model and use that to see what a normal breast looks like and how to feel a normal breast, and then how to palpate a breast that, for example, has a lump. And then they learn how, if you want to make a diagnosis, and they're doing oncology and then they do microscopy, then they'll see videos of how to do a biopsy and then see it. So what I'm trying to say is that they start learning from year two, and by the time they come to the clinical years, what we've also started to do in year three is introduce a model called bench to bedside, which is essentially blood pressure taking, temperature taking, moving a patient, a lot of the nursing skills that unfortunately people like us never learned, because we used to think, hey, this is nurses' work. So we're doing this interprofessionally as well. And so there's another area where interprofessional simulation is used in the early clinical years. So yes, Dr. Akhtar, there is simulation now being used in the undergraduate years and very early in the undergraduate years.
Yeah, and in University of Lahore, which I was mentioning, last year we did a AI simulation physiology quiz through the South Asian Society of Physiology. So that was a very, very interesting experience for me because I have never taught physiology using simulation,
Right.
especially online and virtually. So it was a very humble and great learning experience for me, where students focus on physiology, but they develop clinical cases, and we have given them systems on which they develop case scenarios and they run among themselves, and then there's a quiz actually, and then we announced for second, third positions as well. So it was a great learning experience
Wow.
in
Wow.
undergraduate education as well.
I'll
Wow.
let Dr. Uzair say something. He's
Yes.
very patiently listening us.
Thank you very much, Dr. Faisal. Such a great talk. And be honest with you, if you would have been in sale, you would have been the global president of some company because you know how to sell an idea. A great pitch, I must say that, but we call it elevator pitch. In 3 minutes, and here you go, you are convinced. So what next, really? So amazing, amazing. Uh, so my comment is, for the development and the promotion of any intervention, a supportive ecosystem is very important. So, in the ecosystem, you mentioned there are many components. You mentioned about the limitation of expense and investment in hardware. So, here I have a point. I know some of the people who are developing very, very sensitive precision equipment for the defense industry for Europe, and they are based in Karachi. So recently they developed a ventilator. So they are looking for the ideas. They are also partnered with University College London. So what I will do is that I will get them connected to you. You can invite them to your center, They can see what hardware is, what are the challenges, and they may develop something which is very useful at a fraction of the cost, because that is their social commitment, corporate social responsibility, what they are doing. So they not only developed recently the state of the art ventilator, but oxygen flow meter, that was the patent with University College London. So in that way, there are so many things which are either out of patent, or the innovator, they are very happy to share the patent information. So I can provide this bridging services for you to get them connected, and you can invite them, and maybe they can have of some real help in terms of, considering this obstacle of investment, so that it is quite widely be used, one thing. The second thing is that, as we mentioned about the ecosystem, so we need to, apart from Aga Khan University Hospital, at a national level, to incorporate some of these things with the nursing, with the nursing council, and maybe in the with the PMDC. We had the health commission which survived only for like 3 years, but now I think I was having some insight about the healthcare commission, but now I think again the PMDC is active. So at a curriculum level, trust me, so that's why I give you the gold medal to be the best salesperson. You convince spur of a moment in 3 minutes. So if you just give that, very concentrated bolus 3 minutes, you don't need to add anything, and they are convinced and they are on your side, and they will be happy. And of course, the saving is in terms of satisfaction, and no match, even a single life saved. So I can understand that thing. So there is a somebody we have in the audience, Professor Dr. Noor Mohammad Bhatt, who started with the Atomic Energy Commission like 50 years ago. And he mentioned they were using the simulator 49 years ago. They asked the people to develop the nuclear simulator in their labs. So that's just a brief comment, and Dr. Jabin can have the questions from the question windows, please. Go ahead.
Yeah, I think some of the question, Faisal, you have responded later in your presentation and then in the discussion. It's just like like one of the attendees, Muhammad Naeem Afzal, is asking, is what are the way, like, or what level of teachers you are taking up in NSP? Are you taking head of institution only in this network?
So thank you for that question. No, we're not taking head of institutes. What we're taking is people committed to the simulation task, simulation goal. If you believe in the power of simulation and you are passionate about incorporating it in your institute, in your unit, we'd be happy to have you as part of us. Remember, it's a network, it's not an elite
Mhm.
group. What we're looking is to spread it out as much so that we have a core group of people willing to take this forward.
Yeah, and I too want to add that it is just the core people we bring together, and soon we will be opening it for members to join, and then anyone can join who has an interest, want to know and learn about simulation. I see Dr. Umar on camera. Can you please want to say something, Dr. Umar?
Definitely, that's the reason I turned on my camera just to show that I'm here as well. Uh, Wonderful presentation, as Dr. Azad mentioned. I will say there was a passion and the much needed subject. And that's where the sale pitch come. I mean, sale pitch doesn't come if you are not convinced yourself. And very much needed topic. I mean, I was feeling when I was listening Dr. Faisal, I mean, he should go probably to the every university, to every hospital, to every nursing institute to give this seminar. I mean, it's a cause. The other point which really intrigued me was Dr. Faisal, and I congratulate you on that one. It's not just the education. You started some creativity, some innovations, the tools you are developing, and that's where the value is. Value is not just trainings. Value is, I mean, there is a value, but not. I will call the significant. The innovation, creativity is the value, and you touched that very well. So the it will trigger basically, as Dr. Azad will put you in touch with the other organizations who are working on the ventilators. It will also generate the other IPs, the other tools which are needed for our peoples of who can afford it and locally made. I think that was very important. The other thing I would have to say to all the audience, I have this motto nowadays: run the race where everybody is starting. Don't run the race where the peoples have already left and you will have to catch up. Okay, we need to adopt the artificial intelligence, cell gene therapies, where everybody is starting the race. And it would be where we can make even a big difference. So artificial intelligence, it can be even simply like for even each trainer or each trainee, you can define the customized artificial intelligence and see how that guy is improving over the time. So, no, wonderful talk. Have nothing to add more than that. It was very perfect. Thank you.
Thank you, sir. Thank you very much.
Thank you so much to our panelists, to our attendees, and a huge thank to Faisal for taking out time and sharing all your knowledge and wisdom on a Saturday morning. I think it's late evening in Pakistan
10
right
o'clock
now.
at night.
Yeah, yes. Thank you so much for your time and dedication. Faisal, can you share your email address in the chat? A lot of people want to connect and ask you more. We are
Yes.
2 past the hour. Thank you so much, everyone. And we will see you next time with another interesting topic and another interesting webinar. As I have said, if you want to watch the recording, it will be soon available in the YouTube channel of APPNA. You can join it through a link that Dr. Saeed Uzair has shared with you. If you want to stay connected with the community, please join our WhatsApp group and stay tuned. I think Adil, who works very closely with both of us, is going to present in the next 1 or 2 months, and you will see another paradigm. And a lot of people who are asking, it is cost heavy, it is very expensive. You can see even in low resources how simulation is possible. Thank you so much, everyone. Bye-bye. Take care.
Thank you
Bye-bye.
very much for having me. Thank you. Bye-bye.
Thank you. All the
Bye-bye.
best.
Take care.
Bye. Bye.